and welcome to PHI, Public Health Impact. We are thrilled to be here for our third season of bringing you exciting public health topics from around the state of Georgia.
Well, it's been a busy year here at the University of Georgia College of Public Health and for public health in general. You know, today we're going to be covering current events not only here in Athens, but throughout the country.
And you know, Chan, we are kind of following two storylines today. We're going to provide an update from the College of Public Health, and we're going to have a tour of our new campus, the Health Sciences campus. And then in addition to that, we're going to have an update on the Affordable Care Act. And so we'll have some of our colleagues from the Department of Health Policy and Management joining us today.
In this third season of Public Health Impact, we're going to be interviewing a lot of students. We're proud of our students. They're going to be the thought leaders and leaders in the healthcare system of tomorrow. And a lot of that is because of the hands-on training they get right here in the College of Public Health.
Yeah, I'm really excited about focusing on students. Today, because we're talking about the Affordable Care Act, we'll have two students who are working in the healthcare system and are really seeing what's happening with healthcare reform firsthand.
Well, we have a packed show today, so let's get started with Phil Williams, the Dean of the College of Public Health, and where we fit in the field of public health.
Dean Williams, we have a new expanded viewership for the TV show, and we're really excited about that, but we suspect that many of our new viewers don't know what public health is, so we thought we would have you join us today and tell us, what is public health?
Well, public health as a definition can be a little difficult to explain, so I think probably instead of giving you just a definition, I'll give you some examples of what public health is. Public health is wearing our seatbelts when we get in our vehicles. It's getting a flu shot. It's having safe water to drink. It's having clean air to breathe. It's having a safe food supply. It's all the things that we do collectively that prevent injury and disease in population. So it's prevention-based and it's population-based. And
tell me about the College of Public Health.
Well, we've been in existence since 2005, and we've grown steadily since our creation. We now have nearly 900 students. We have about 60 full-time faculty and about 150 or so full-time staff, most of whom work on funded research projects. And we cover all the areas that are traditionally covered by an accredited school of public health. We have academic disciplines of biostatistics, environmental health, epidemiology, health promotion and behavior, and health policy and management. We have both academic programs as well as research going on in all those different areas.
What should we expect from the college in the future?
Well, I think we're going to continue to grow. We're very excited about the fact that we're in the process of moving from a variety of locations in the Athens area to one location being the new Health Science campus. And at that location it will allow us to come together and be able to be more interactive between the departments. The problems in public health are so complex that no single discipline can address the problem, and so we need to be able to work across departments, and we've always done that, but we can do it more effectively when we're logistically closer together, and so we're very excited about the fact that we're going to be moving there. The other thing that we're doing now is that we're able to put public health professionals out into the communities, and as I said before, that public health is prevention-based and population-based. To deliver those services, you have to live and work in the communities, and so we've been able to put public health professionals in a variety of different locations across the state, and we have individuals that actually live in those areas but work for the college and coordinate back with the college to identify issues that need to be addressed in those communities, but yet find resources here in Athens that can deliver solutions to those communities. And so we're very excited about that as well.
So I'm here with Eric Dahl, who's one of our associate deans in the College of Public Health, and we're on the Health Sciences campus. Eric, tell us, how did we get this property? It's pretty amazing space, but I'm sure there was a process involved.
When the Navy decided to move the supply school to Rhode Island, there was a process to select a new use for the facility, and the idea was to find whatever was best for public benefit. There were several proposals, but UGA proposed a health sciences campus to train public health professionals and doctors, and that was what was selected by the Reuse Authority.
It's a beautiful campus. We're thrilled to be here, but I'm sure there's been some challenges along the way. Can you tell us a little bit about that?
One of the interesting things was watching the architects work with our faculty to understand how they do research. And they learned that a lot of the really important research in public health doesn't involve wet labs. It involves groups of people going into the community or collecting data to do population studies. So they had to design something a bit different so that these kind of collaborative research projects could happen. We still need wet labs. We'll have to, there aren't any here yet, and for the Environmental Health Sciences group to move here, we'll have to develop those, but that'll come in time. Another interesting thing was the growth of public health during that time. You're planning for a new facility with a program that is really dynamic. We thought by now public health would have 400 or 500 students and a research footprint of $10 million. And instead, today, there are nearly 1,000 students, and our researchers are really productive. Our active grants are 22 million. So it's a problem to plan for a program that's growing, and I think they've done a real good job, and it's the kind of problem you want to have.
So it's fall 2012. There are a few of us over here on campus. What are the future plans for construction?
Well, Public Health, Department of Epidemiology and Biostatistics moved here in January. That was the first unit on the campus, and by fall, Russell Hall was completed, and that's the main instructional space. Winnie Davis has been established for the Dean of the Medical Partnership, and as we speak, there is construction going on inside of Rhodes Hall. The interior walls are being torn out to make a space for the Dean and all the administrative support groups for research, instruction, and outreach.
Eric, what does this campus mean for the College of Public Health and for the community?
Well, for the college, it really brings together units that are currently located in 7 different locations on the main campus, downtown, and here. And that just means we're going to be more efficient, more effective in working together. That has lots of implications, and they're positive. The community, I think most immediately, now has access to the campus, and the president has invited them here, and the black steel fence in the front of the building has been taken down. But over the long term, Health Sciences Center with this kind of teaching and research activity is just real beneficial to the economy. And I guess the real answer is this is an opportunity for the community and the college and the university and the state that's immediate and will happen over the long term as well.
Man, that looks great. It's going to be so encouraging to have that critical mass where we have all our programs and the departments together on one campus.
I agree. Now let's turn our attention to the Affordable Care Act and remind our viewers on what's happened with the Affordable Care Act so far before we bring in our experts to find out what might happen next.
Well, this is a big act. It has a lot in it. So let's just, for time's sake, let's hit the high points. The law has extended parents' insurance benefits to young adults up to age 26. It has ended pre-existing condition clauses for children. It's closed the Medicare donut hole and eliminated co-pays for many preventative services.
And so, Chan, the next big wave of changes from the Affordable Care Act that we should see by 2014 are ending pre-existing condition clauses for adults, establishing the state-based health insurance exchanges, extending federal tax credits to families to pay for health insurance, and then potentially expanding Medicaid coverage in some states.
Now that we have the general provisions of the Act spelled out pretty well here, I think we ought to go to the student guest and that has been doing research on the recent critical decision by the Supreme Court on the Affordable Health Care Act.
To highlight one of our amazing students, I have with me now John Costantino, who is a second-year MPH student, and you also have a unique background in that you're a practicing attorney, is that right?
Yes, I am.
So over the summer, you worked on the case law and thinking through the case law around the Supreme Court's decision on the Affordable Care Act. So I was wondering if you could tell us a little bit about what was the Supreme Court deciding?
Well, essentially, the Supreme Court was trying to decide whether or not the Affordable Care Act, as written, specifically the individual mandate portion, was constitutional.
And what law were they looking at in that regard?
Well, they were trying to look at the legislative powers under the Constitution, which grant Congress the power to write certain laws, specifically the power to tax, the power to regulate commerce, and the necessary and proper powers.
Okay, and what did they decide?
Ultimately, they found that the individual mandate was a proper use of the taxation power, which was a big surprise. Most people assumed it would come under commerce.
Okay, and explain to me, what does the Commerce Clause say?
The Commerce Clause allows Congress to regulate anything involved in the channels and instrumentalities of interstate commerce, they call it. Basically, anything that's bought or sold or moves between states, Congress is allowed to rule on.
And so they decided that that was not the issue, it was the taxation power of Congress.
Yes.
Okay, and what other decisions were they making?
They were also deciding on whether or not a few obscure acts like the Anti-Injunction Act applied, which would have prohibited them from hearing the case until 2015 when taxes actually became due. They also were supposed to consider the severability issue had the individual mandate been struck down, whether or not the rest of the law could stand. They also considered, most importantly, the expansion of Medicaid under the Affordable Care Act.
And what did they decide?
This is an interesting thing that the court did. The court actually changed the law a little bit. The law, as written, said that states were required to take these expanded eligibility standards for Medicaid. The court said that that was coercive by the federal government and therefore changed the law so that it was an option that states could opt into these expanded coverages and get paid accordingly.
And were you surprised?
I was very surprised. I was surprised by the decision as a whole. It was definitely different than what everybody expected, myself included.
And implications for the future?
There's actually a really interesting case out of Montana right now. The state of Montana is working on passing a law that prohibits them from enacting the individual mandate or the Affordable Care Act, which will certainly get worse before it gets better. It will be an interesting thing to see how the courts decide on that.
Great, so we should stay tuned.
Absolutely.
One aspect of the Affordable Care Act that we all have questions about is how much is it going to cost? So we brought our health economist here today. Her name is Dr. Jayani Jayawardena, and hopefully she can answer some of those questions for us. Jayani, my first question for you is the price tag. Even those of us who want to see a reform of our healthcare system are worried about how much it's going to cost.
Yes, the projected price tag for the Affordable Care Act right now is about $1 trillion.
That's a really large price tag. How does the federal government plan to pay for it?
Well, the federal government will impose a higher Medicare tax for families that is earning more than $200,000, and also medical device companies and also pharmaceutical companies will also be taxed more in the future. And also there will be a penalty imposed on people who will not be part of the, who will not buy insurance through the Affordable Care Act.
Okay,
program.
so there's parts in the legislation that are paying for the other parts, it sounds
Yes,
like.
definitely.
And so who comes up with the estimates?
Well, it is the Congressional Budget Office that comes up with the estimate. It is a nonpartisan independent organization that provides economic and budgetary evaluations to the federal government.
And so, you know, there's been a lot of talk about, from the Republican Party in particular, about repealing healthcare reform. Should they take over in November? And I'm wondering how will that impact the costs?
Actually, interestingly, Congressional Budget Office has outlined the cost projections if the repeal were to take place. Projections from the Congressional Budget Office implies that there will be about reduction in spending, about $890 billion, but there will also be a reduction in revenue that is close to $1 trillion. So together these numbers means that there will be additional $110 billion added to the federal budget deficit within the next 10 years or so.
And so with the Supreme Court coming up with decisions around the Affordable Care Act over the summer, what does this mean for the price tag?
So one of the rulings, one of the results of the ruling that took place in the summer is that now individual states can make a decision on whether or not to expand their Medicaid coverage. And as a result, some of the states have already decided not to expand the coverage. So because of that decision, the price tag has been reduced by about $84 billion now.
So I know the Medicaid expansion is voluntary now. What's happening in the state of Georgia around that?
Well, state of Georgia has decided not to expand the Medicaid coverage. However, if they were to decide on expanding the coverage, the cost would have been additional $76 million added to the state budget. But that also means it would have added about 600,000 more individuals to the Medicaid program. But now, given that Georgia is not expanding the Medicaid coverage, of course, the additional cost of $76 million won't be there. However, we don't know the impact of the uninsured people, what it's going to be on the state budget in the future.
Sure, long term it could be worse, right?
Definitely.
So other than dollars that a state could receive in revenue from the federal government for expanding Medicaid, what other funding streams might Georgia expect to see?
So one of the interesting part of the Affordable Care Act is that it has a focus on preventative activities across the United States. So they have allocated about $16 billion that can be spent within the next 10 to 11 years or so across the United States. So Georgia actually has received about $352 million so far through this prevention fund that can be allocated towards preventative activities in our state.
And so who are some of the places that have received the funding?
Some of the counties that have already received funding are DeKalb, Fulton, and Cobb counties. And for example, DeKalb County has focused on tackling tobacco cessation within their county, while Cobb County has focused on tackling cardiovascular disease and cancer prevention activities.
Thanks so much, Jayani, for helping us figure out the costs of the Affordable Care Act. That was very helpful. In addition to being an expert in health information technology, Dr. Neil Chumbler is also the new department head in health policy and management. We're so glad for you to join UGA.
Well, thank you. It's a pleasure to be here.
My first question for you, Neil, is just this term, health information technology. I think most people, including myself, have no idea what that means.
Well, that's quite all right. It's actually an umbrella term that defines encompassing health information such as computerized patient record systems or video phones to help the patient and the provider communicate about their health conditions. So you used to go to the doctor and you say you had a problem with a symptom, and he or she would use a paper and pencil and the old-fashioned chart and document that. Now you'll go to a doctor's office and many times they'll have a computer, a laptop in there, and they'll enter the information, and then that electronic medical record would encompass all your health symptoms and conditions over time so that the provider could then have information at their computer to make wise, timely decisions about their condition.
And because we're talking about the Affordable Care Act today, is there anything in the Affordable Care Act that speaks to health information technology or electronic medical records?
Right, so by 2015, that all hospitals, private hospitals, are to show documented use of electronic medical record with the purpose of improving the quality of care and giving quality of care to their patients.
One of the other areas that you mentioned was telemedicine or telehealth. What does that mean?
Yeah, so that is, once again, a branch of health information technology, and it could be as simple as a doctor calling the patient and communicating through the telephone. But in recent years, there's been such things as video phones and messaging devices that have been used between providers and their patients to communicate to their patients, but also to increase access to care. I've studied a lot of telehealth in the patient's home. A lot of individuals living out in the community unfortunately have a lot of chronic health conditions, say, for instance, diabetes, hypertension, heart failure, that need constant symptom monitoring or oversight. And a telehealth device in a patient's home could link that patient to a nurse or another alternative provider that can help reassure the patient that his or her symptoms are natural, right? And so I found in my research that the telehealth information has the best impact for older individuals living out in rural areas that have transportation problems and have to travel long distances to their nearest healthcare provider. And it's also, in many rural areas, very few specialists, medical specialists, practice in rural areas.
Well, thank you for being here, Neil, and we're excited that you're bringing another area of research to the College of Public Health.
It's been a pleasure.
We're here with Dr. Monica Gahn, who's been with us several times to talk about healthcare reform, so thank you so much for being here. So we have an election coming up. I guess my first question for you is what might happen with the governance structure from the election?
Well, it's a national election. It's a presidential election, which I'm sure our viewers know about, but there are also some very important congressional elections that are occurring in both the House and the Senate. Georgia does not have a Senate campaign right now, so we may not be fully cognizant of the fact that 1/3 of the Senate will be turning over in November.
And you know, I like that we're talking about Congress and not the presidential election, right? Because that when we talk about Affordable Care Act, we always talk about the president, but why should we care more, almost more about the Congress than anything else?
Well, one of the things I tell my students is that in one sense, President Obama has an easy job because he has a bill that has been passed by the Congress that he signed, and the vast majority of it was upheld by the U.S. Supreme Court. So he's in the middle of implementing something. And so when people say, well, what are you planning to do with health care? He has a very large, we talk about how big it is, plan for how health care reform will happen. So we don't expect any big changes coming from a second Obama administration. However, because it's being implemented, he has to rely on Congress to be able to fund the implementation of these aspects of the Affordable Care Act that haven't gone into place yet. And so that's where he really needs a Congress to be helping him to fund it. Of course, he wants them to help. But if Congress swings more Republican, the Republicans will be in a position to be able to slow down some of that implementation through simply not funding some of the provisions of the bill.
Right, so it makes sense that we should be following Congress more in this election than the president. But if it is the case that Governor Romney wins the presidency, will he have the power to repeal the act?
Well, no, he does not have the power to repeal. He's the president. And so just as President Obama provided leadership to Congress that this bill was something that he would like to see happen and then let Congress pass the bill. In order for a bill to be repealed, it has to be repealed by Congress. So what we would expect from Governor Romney if he's elected is providing leadership to his party in the Congress toward repealing the Affordable Care Act.
Do you think if they do decide, if he wins the election as president and he's able to persuade Congress to repeal it, do you think they'll come up with an alternative solution for our healthcare system?
I think of necessity they will, because there are a number of elements of the Affordable Care Act that have already been implemented that are very popular. So if it's repealed, that would mean that Governor Romney, or then President Romney, and Congress would need to go back to their constituents and explain, for example, why children under 26 are no longer able to stay on their parents' health insurance plan, why the donut hole in the Medicare prescription drug program has opened back up, pre-existing condition clauses for children and for adults will be back in play. And these are very popular features of the bill that are already in place.
What happens next in terms of timeline, you know, regardless of who wins?
What happens is we have a new Congress being seated in January at the same time that President Obama is either starting his second term or Governor Romney is starting his first term as president. And then it kind of becomes politics as usual, which is back to our political process, which tends to be a slow-moving process. So whether it is President Obama continuing to implement his Affordable Care Act or Governor Romney, then President Romney, attempting to change it, it's going to take time because it involves Congress.
We're with Smitha Ganeshan. She is an honors undergraduate student who's taken quite a few classes in our college, and she has done an amazing internship this summer around the implementation of the Affordable Care Act, and I can't wait to hear all about it.
Well, thank you so much for having me.
So tell me, what did you do?
So this summer, I was interning with the Greater New York Hospital Association with the Executive Vice President and General Counsel for the Greater New York Hospital Association. And so really I was working on looking at the evidence, looking at what the most effective programs are, and then translating those into guidelines and protocols that hospitals could actually implement.
Give me an example of one of the protocols that you liked the most.
One of the most difficult things is really addressing substance abuse and mental health in a physical health setting. One of the programs that I looked at was a screening system for people with alcohol and substance abuse. So right when they come in, when we triage patients, this would be a way to identify those patients who had substance abuse. It was a way that doctors could realize that they had this issue and kind of tailor treatment protocols to address those concerns as well.
So almost a universal screening?
Absolutely, right. And it really did improve hospital readmissions rate, those quality indicators that we've been talking about and that the Affordable Care Act kind of harps on.
Well, it sounds like you had a great internship. You're an amazing student. We all love you, but I think our audience would love to know, what are your plans for the future?
I'm pre-medicine, and so I'm really interested in serving as a provider preferably in a primary care setting. But I'm also really interested in health policy. So I don't quite know what it looks like 10 years from now, but I'd like to kind of combine that interest in health policy and in medicine, and use my experience in the field of medicine and in the healthcare system to inform policy.
You're one of those rare people who want to take individual clinical medicine and pair it with population
Right.
health, right? So
Right.
that's really wonderful. Well,
Absolutely.
thanks so much for being here.
Thank you so much for having me again.
Well, thank you all for joining us today. We hope that we've clarified some of the uncertainties you may have had about these new and exciting developments in healthcare reform.
But let's remember, this is an evolving process with healthcare reform, and so even if we have new leadership coming in this year, we might see some differences in the act, and we'll be here to discuss it.
In addition to this hot topic of healthcare reform, we're going to be covering a lot of other interesting topics this year in the third season of Public Health Impact, such as infectious disease, employer-funded wellness programs, and emergency preparedness.
So thank you all for joining us today on PHI Public Health Impact.